again, to move on for the sake of time, we now have a second FDA-approved drug, Fedratinib, in myelofibrosis. So I'm going to turn to Ruben to discuss the clinical trial data. And then I'm going to ask Serge to talk about how do you, since they're both indicated in the first line setting, how do you choose between these two? So let's start with Ruben.
Well, there are really two main studies. Firstly, the pivotal study, which was the JAKARTA study, that looked at two different doses of fedratinib, 400 and 500 milligrams, versus placebo, and it showed without question, vast superiority in terms of control of spleen and symptoms. And reminding folks, again, this was several years ago, so this was kind of concurrent during the approval time of ruxolitinib. So this, this is a different study that might have been done if it was, much more recent. So it clearly showed benefit without question. Side effects included some GI side effects, potential for cytopenias, and in a very small number of individuals, a neurologic side effect that was potentially related to Wernicke's encephalopathy. Close look at that still puts that somewhat in question, but the agent is approved, but with a black box warning to monitor for thiamine, replace thiamine before patients begin on the therapy, and monitor for Wernicke's. Functionally should not be a large issue in that this was a pretty rare side effect, and should be prophylaxed with thiamine. So clearly that is the basis of that frontline approval. The delay in approval was, again, resolving this whole issue of thiamine, Wernicke's, and as well as kind of the drug development pipeline and delay. There's also a second line data with a second line trial led by Dr. Harrison from the UK, and myself and many of our colleagues that we've recently updated at ASH and EHA and recently published, that found a good 30 to 35% response rate for spleen and symptoms in the second line setting for individuals that had failed ruxolitinib by relatively rigorous criteria in terms of resistance or intolerance. So clearly active in the second line setting for people that had failed ruxolitinib. We're very pleased to see the now commercial availability of a second agent, and certainly something that people should be considering for their patients that have failed ruxolitinib, that you do not have a good alternative clinical trial for them to consider. Certainly fedratinib is approved and an option for these individuals. I will make one comment on dose as well. In the pivotal study, there was both the 400 and 500 milligram dose. The 400 milligram dose was felt to optimize efficacy, and there was more toxicity in the 500 milligram arm, so 400 milligram is the dose.
Christina, the other toxicity is GI toxicity with diarrhea. Is there anything special that you do or tell your patients?
Absolutely. I think really setting the stage for the potential side effect of diarrhea as a toxicity, so they're anticipating this, is extremely important. And then certainly co-administration with some of our great antiemetics, which we now have available. There is subneurokinin, which is oral, which I have been using for patients who particularly have a history of being sensitive to medications and are potentially at high risk for significant nausea. But diarrhea is really a problem as well. And so certainly managing the symptomatic diarrhea with Imodium, Lomadol, and even have gotten some GI input for patients that potentially may need some more advanced therapies for managing the diarrhea.